Hello, good evening, good day, everybody. It's another time for our lectures today. Today we'll be briefly looking at an overview of managing of clients with endocrine disorders. During the course of this lecture, I'll be using the term metabolic disorders or endocrine disorders. I might be using them interchangeably. So, before we go into the management proper, I want us to look at the anatomy and physiology of the endocrine system itself. Let's just look at the overview. Um, the endocrine system is a very complex system because it contains it's a network of glands and organs, and what they do is they store and they secrete hormones. So because they store and secrete hormones, and then these hormones, they regulate our metabolism, they regulate the body functions, they regulate your growth, reproduction, homeostasis, everything that is needed for proper functioning and metabolism. Okay, that is what they do. And we have there's some organs, there's some major organs in the endocrine system. So we have the first one I have here is the hypothalamus. The hypothalamus is part of the brain. It's located in the brain, and then it serves as the link between the nervous system and the endocrine system. During the course of our nervous system, we talked about the hypothalamus. The hypothalamus is the part of the brain that functions, that regulates the involuntary activities like your hunger, your thirst. It regulates sleep. It helps to control your hormones as well. So it has function. It functions in the nervous system and also functions in the endocrine system. So um, we also have the pituitary gland. This is another very major endocrine gland, and it's often called the master gland because it controls all other endocrine glands. And then it's divided into two. We have the anterior pituitary lobe and then the posterior pituitary lobes. The anterior pituitary does most of the work. It's involved in the growth hormone, the thyroid stimulating hormone, the prolactin, the follicle stimulating hormone, and all the rest. While the posterior pituitary gland is mostly involved in oxytocin and the ADH. Oxytocin is needed when women are giving birth. It helps in the uterine contraction, and the antidiuretic hormone. This is mostly involved in diuresis. Diuresis I mean by urination. So, but all other hormones, the thyroid glands, the thyroid hormone, the growth hormone, all the catecholamines, all of those, the estrogen, all of those are from the anterior pituitary, where the posterior pituitary is just the oxytocin and the ADH, antidiuretic hormone. So we have another gland, the thyroid gland. We all know where our thyroid is located. The thyroid gland is located anterior part of the neck. Okay, and then this thyroid gland helps to produce two major hormones. That's the T3 and the T4. T4 is the thyroxine, and the T3 is the thiiodotyronine. Both of them helps in majorly growth. Okay, it determines how tall you are, it determines how tall or short you are. It determines it also helps in the production of calcitonin. Okay, and this further helps to regulate your calcium levels and your calcium levels basically. Like I said, they're located in the neck. So when there's an enlargement, you can see people with goiter or other thyroid disorders. You can see the enlargement of the neck because that is where the thyroid gland is. Then we have the parathyroid gland. This parathyroid, going back to our lesson when we heard about the introduction to anatomy, the para means around, like it's all around. So the parathyroid glands are situated around the thyroid gland. So there are four in number and they are located at the back. That's the posterior, at the posterior surface of the thyroid. And they regulate in calcium, but most importantly, phosphorus level. So they help to regulate the phosphate levels in the body. We have the adrenal gland. This is another very important. In fact, all of those glands are very important. All the endocrine glands cannot, none of them can be done without. They are very important in their functions. The adrenal glands, they are split into two areas. We have the cortex. Unfortunately, I don't have a diagram here. You could have appreciate this explanation. We have the cortex and the medulla. The cortex produce corticosteroids. Corticosteroids. So when you are stressed or when there's need to absorb more water for sodium water balance, the corticosteroids will ensure that that is sorted. And we have the adrenal medulla. I mentioned catecholamines earlier on. Catecholamines is mostly produced by the adrenal medulla, and catecholamines they are our epinephrine and norepinephrine. We have them for flight and flight response. When you are scared, when you when you are scared, some people react in terms of flight, that means they run away, while some of us react in terms of fight. They are ready to face the problem. They are ready to fight. So it depends on your nature, depends on your genetics, either flight or flight, whatever you decide to do, that is decided by the catecholamines. That is the epinephrine and norepinephrine, and they are produced in the adrenal medulla. We have another very important one, the pancreas. The pancreas helps in production of insulin. That's very, very common. Everybody knows the pancreas helps to produce insulin, but that is not just the only function. It produces insulin and also glucagon. So when the blood sugar is high, there's insulin produced into the body system, into the bloodstream, and helps to lower the blood glucose level. Okay, but when the blood sugar level is low, it also helps to secrete glucagon. This glucagon the helps to increase, go through some series of processes that helps to raise the blood sugar. Okay, and it is worthy of note that this pancreas can function as both endocrine and endocrine gland. So it's both endocrine and exocrine gland.
Cerebral RN going on.
So
I
um,
don't know. I just saw their this in the post now. Lectures going on.
um, even though this topic generally is disorders of the endocrine gland, but because this is an endocrine gland, but it also function as an exocrine gland. So I think we should just give just a little bit of explanation about the differences between endocrine, as we have here, endocrine and exocrine gland. Endocrine gland, endocrine glands are glands that they secrete hormones, like their hormones are secreted directly into the bloodstream. Okay, so from the from the thyroid gland, it secretes the thyroid stimulating hormone directly into the bloodstream. Your estrogen, okay, your pancreas, it secretes the insulin directly into the bloodstream, and it helps to reduce the blood glucose level. But exocrine glands, the main difference is exocrine glands secrete their own substances through duct. So there's like a pipeline is a duct that carries the substances from exocrine glands. For instance, your sweat does not just magically appear on your skin. No, it comes through a duct. Okay, like the salivary glands. The common example that we have in anatomy is the mammary glands. So the breast milk does not magically appear um, for kids to suckle on. Rather, it comes through ducts. It goes through a duct before it reaches the endpoints for kids to suckle on. So that is a very typical example of the exocrine gland. So the pancreas functions as both. It's an endocrine gland because it secretes insulin, and it's an exocrine gland as well because it helps in the production of glucagon. Right. Moving on, we have the gonads. Gonads is just another word for um, the reproductive organ. So we have the ovaries for women, and we have the testes, which is typical to men. So the ovaries produces estrogen and progesterone. So they help to regulate the female reproductive function. And while the testis is just producing the testosterone, which helps to regulate the male reproductive function. These are things we know already. Just a recap, recap of the anatomy before we go into the disorders. Okay, then we have the pineal gland. This pineal gland is not really popular, but it's very it's very we cannot but mention it because it produces melatonin. This helps in sleep-wake cycle. So those of us that work night shift, I'm sure you see all of us are nurses. We don't shift, we run shifts. So those of us that work the night shift, probably we are messing up the our sleep cycle, and it will ultimately affect the production of melatonin. Okay, right. The last on my list here is the thymus gland. This helps in immunity. It helps to produce the thymosin, which helps in production of in the maturation of T cells. This one helps in our immunity. Right. Looking at all of these main organs, we can tell. For instance, if there's the thyroid gland, okay, if there's a problem with the thyroid gland, we know that the thyroid gland helps to regulate metabolism, energy production, and growth. Okay, so when you see somebody that has stunted growth, I mean very short compared to his expected height, or someone that has that is excessively tall, so we know the person has issues with growth disorders. Ultimately, we can know that this person has problem with the thyroid gland. Is either the thyroid gland is having problem, or the tyrosine or triiodothyronine, they are not effective, or it is not sufficient. So you can easily pinpoint where the problem is coming from. Okay, if somebody has common example, diabetes. So when if your patient has diabetes, you can narrow it down to the to the causing organs, because the pancreas helps to secrete insulin that helps to lower blood glucose level. So you can easily tell, you can easily know. It will help you in your diagnosis, assessment, and care for that patient. You can know that this problem is from the pancreas. Okay. Um, if another example that's common here, um, right? Let's go to the parathyroid glands, because most people forget the parathyroid glands and focus more on the thyroid gland. So when your phosphate levels are high, your calcium and phosphate levels are not regulated. So you can know that there's something wrong with the parathyroid glands, because the function of the parathyroid gland is to regulate the phosphate levels in the body. Okay. Coming to the posterior pituitary, the woman in labor, and the uterine contraction is very poor, is insufficient to proceed with the labor, with the delivery of the baby. Okay, you can tell that this woman probably needs some assistance, and then you give oxytocin. So those are the things that will help you care for your patient when you have the proper understanding of the endocrine organs and their normal function. So when you know the normal function, you can tell, or you can be effectively care for the person when there's a malfunction or there's a disorder. Okay, moving on, we want to talk about the roles of hormones in metabolism. So the are things we've talked about already. We have the insulin. The insulin is very, very common. It helps to lower the blood glucose level. We have the glucagon is the opposite of the insulin, so it does the opposite. It elevates the blood sugar. We have the thyroid hormones T3 and T4. Thyroid hormones, yes, I need to mention that the thyroid hormone, they do not only help in growth, they also function in basal metabolic rate. Now, what is basal metabolic rate? The mere fact that you are existing, you are awake, even if you are sleeping, the amount of energy needed by your body to maintain the minimum function, like your heart is beating, your sweat glands are working, your uh, respiratory system is functioning, you know, that's the basic, that minimum energy, that basic rate is what you know as basal metabolic rate. So the amount of energy spent at a minimum while at rest is of basal metabolic rate, and that is you know that helps. That is part of the function of the thyroid hormones. So when at rest, you you consume more energy, okay, and your heart is racing for no reason, your temperature is high for no reason, you are hyperactive. That means probably you have too much of thyroid hormones in your body. Okay, that's why we have hyperthyroidism. And then we have hypothyroidism. That is when the person is just calm, sluggish, cold, and all those basal metabolic rates are so low. So the person is so sluggish and so slow. So you can tell that this person has hypothyroidism, which has caused a very low basal metabolic rate. I hope that is clear. Then we have cortisol. We talked about the adrenal cortex. This helps to it promotes glucose production and protein breakdown. Talked about growth hormones, self-explanatory. It helps to stimulate growth. Now, what is metabolism? We're going to be mentioning metabolism quite a lot here. Metabolism is just a chemical process. It's just a reaction that occur with the body to maintain life. So it's just a series of processes that happen within the body. Okay, and there are two: catabolism, which is breakdown of molecules to release energy, and then anabolism, that is the synthesis or manufacture or coming together of molecules for growth and repair. So those are the two major types of metabolism. Still on the anatomy, I think we need to move fast so we can go to the disorders proper. Carbohydrate metabolism. So glucose is the primary energy source of energy, source for fuel for cell, and insulin facilitates glucose uptake. So when you've eaten and the food is broken down in your body to release glucose, there's a lot of glucose in your blood. What insulin does is it comes in and then helps the glucose to be taken by the cell. So it drives the glucose into the cell where they are needed. The glucose is needed in the blood, in the cells, in your body cells, not just in the blood. So the glucose helps those cells to take up all the glucose you have in your bloodstream. And glucagon does the opposite. However, when you've got too much glucose that's roaming about and the cells are not needed anymore, and the cells don't need them anymore, they are stored. They are stored in your liver primarily and then your muscles. The funny thing is you as a person cannot decide which muscles is gonna store all of this glucose. So it's possible the glucose are stored in your in your belly, your tummy. Some of them are stored in the gluteal muscles. Some of them are stored wherever the genetics decide. Okay, so but the basic line is that excess glucose is stored as glycogen in the liver and in the muscles. Now, protein metabolism. Protein are broken down to amino acid, which you need for growth and repair, and also for energy production. Okay, so excess amino acid are now converted into glucose or fat. Then we have fat metabolism. Fats are broken down into fatty acid, which are used for energy production, and excess fat is stored in adipose tissue. So, just to recap, glucose carbohydrate is broken down into glucose, protein is broken down into amino acid, and fat is broken down into fatty acid. Excess carbohydrates stored as glycogen in the liver and muscles. Excess protein is stored as fat into or yeah, converted into glucose or fat, while excess fat is stored in adipose tissue. We've talked about all of this, the insulin, thyroid hormones. This is another very important thing we need to talk about. Now, how do you regulate metabolism? Because, for instance, how does the pancreas know that the insulin produces enough? How does the posterior pituitary know that you've had enough oxytocin? Okay, how does all of this regulation come into play? It's divided into two mechanisms. You have the negative feedback mechanism and the positive feedback mechanism. So the most common one is the negative feedback mechanism, and this helps. The way this works, it works by reversing changes. Okay, so what it does is it functions in a reversing order. Why positive feedback mechanism function in an amplification order? Let me give you an instance. Um, let me see if I have it. Okay, so negative feedback mechanism when there is when you've eaten and there's excess glucose in the blood, what happens? The pancreas secretes insulin. It will continue to secrete the insulin until the levels of the glucose in the blood is reduced as is low. Now, when the level of glucose is low in the blood is low, the production of insulin stops. So it reverses the order. When the production of insulin is when the glucose in the blood is low, then there's glucagon to reverse the order. Then there's glucagon. Glucagon will help to increase the blood level of this blood glucose level. Another example is, for instance, growth hormone. Normally, the growth hormone helps to regulate your growth, ensure that you are at the right height for your age. Okay, but when the person is now getting excessively tall, then the growth hormone, which is the thyroid stimulating hormone, stops. It stops the secretion of thyroid stimulating hormone, and there's no further production of thyroid stimulating hormone. There's no further production of growth hormone. That is a very clear example. Okay, and in positive feedback mechanism, there is no reversing changes. There is no reversing order. What happens in this mechanism is there's a continuous production or continuous secretion of the hormone until a specific reaction, specific outcome is achieved. The common example is childbirth. The two examples under this is the oxytocin. Okay, that's a very common example. So during childbirth, the posterior pituitary will continue to secrete oxytocin until there's no more baby in the uterus, until there's an outcome, which is the birth of the baby. So as long as the baby is in the uterus, there will be continuous secretion of oxytocin. So that's the difference. In the negative feedback mechanism, it works to negate itself. When there's low sodium level, the action kicks in until the action is reversed. But in the positive feedback mechanism, it will continue to secrete the hormone until the desired outcome is achieved. But in negative feedback, there's no specific action. It's just reversing of that. When it's high, when the blood level of the blood level is high, it will come in, bring it down. Then if it is too low, it also comes in to raise it. So it's just back and forth, up, down, up, down. But in the positive, it continues to increase high, 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 high until it is no longer needed. So when you are faced with a client with endocrine disorder, as a nurse, you are expected to be able to give a thorough assessment of patients, and your assessment should be organ specific. What I mean is, a client having an endocrine disorder, okay, for instance, the client have the patient is diabetic, okay. You should ask questions. Your assessment should be related to the disorder. So if the patient is diabetic, there is no reason for asking questions that are not relevant or that have no significance to the case. The first thing you ask, the first thing in our assessment is health history. You want to know what the patient is complaining of. So Mr. Jones has come to the hospital complaining of according to this note, fatigue, weight changes, heat or cold intolerance, um, change in appetite, thirst or urination. So you should be able to, it will guide you to the cause. It will guide you to the organ. It will guide you to the part of the body that is having the disorder. Okay, so this is just a general overview of an array of symptoms that can be presenting. So this is not specific to a disorder per se, but this is just a general overview of presenting complaints of patients with endocrine disorder. So, for instance, if somebody says he or she's always fatigued, there's loss of weight loss here, okay, and the person is cold intolerance, okay, there's low appetite, okay. What does that tell you? That means this person probably have hypothyroidism. Okay, because when we talk about hypothyroidism, we know that the thyroid hormone helps in metabolic rate. All right, and the person says these weight changes could be high. I mean, increase weight or reduce weight. But for the person or the patient, she has weight loss. Okay, and always hot. Okay, increased appetite and thirst. Okay, that shows you that that person might be having hyperthyroidism. That is why, because the metabolic rate is increased, that's why the person is having weight loss. The person is using up more energy. The person is always hot because the basal metabolic rate is high. The person is eating more because energy needs to be replenished. The person is having increased thirst. Okay, so it gives you a clue that this person is probably having hyperthyroidism. Okay, so generally you ask questions. This presenting symptoms is what the person is complaining of. This is just like a very large aggregation of symptoms. Okay, so it has to be specific to the condition. For instance, a patient with diabetic mellitus, the common presenting complaint for patients with diabetes is eating. The person is eating too much. Patient is increased thirst. The person have that's hyperglycemia, hyperphagia, eating too much. The person has dry. The person is drinking more water because of the glucose. The oral mucosa are dried up. Okay, so those are the examples of symptoms that will come in when a person has diabetic mellitus. So when you get that, then you go to the past medical history. You want to know what the patient is like. Any relevant past medical history. Has the person have history of endocrine disorder before? Has the person has diabetes before? Has the person have any other disorder before? You need to know. Okay, any surgeries, any radiation, like um, people might have gone through surgeries, surgical operation. For instance, if somebody has goiter as a kid or as a teenager, and the thyroid gland is taken off, okay, and now the patient is here to you complaining, talking about symptoms of hypothyroidism, all right, and then during your past medical history, you realize that the thyroid gland is taken off. So that helps you know that the reason for having that hypothyroidism is because probably the patient has had the thyroid taken off due to cancer or due to tumor or whatever, or probably following an accident. Okay, so anything might have happened. So to give you a clue of why your patients are having some of those symptoms. So past medical history is very important, and it is not complete without family history. So if the parent had diabetes, okay, then there's a chance because there's a chance that that person also has the diabetes because the family it runs in the family. Some medications also affect it alters the functions of metabolic organs. Okay, so if you are using some medications, it could also cause some of the symptoms that patients present with, and lifestyle factors. All of this is under your history. You are taking the history of the patient. So it includes presenting symptoms, past medical history, medications, and lifestyle factors. Is a patient a smoker? Does he drink? Does he use alcohol? What is the work life balance? So those are the things that you need to put into consideration. And the reason we are asking all of this is that when you, apart from the medical treatment, from the therapeutic, I mean, pharmacological treatment, your nursing intervention should also address some of the things you discovered during history taking. So, if your patient is a smoker, by the time you start talking about nursing consideration, you should address the issue of smoking. Okay, if the person works in a company like in a factory that exposes to cytotoxic chemicals, to dangerous chemicals, your nursing consideration should also include advising the patient to look for a better another job to reduce exposure to those very harmful substances. That is why you are taking this history. They are very, very relevant. Then, after taking history, you go to physical examination, general appearance. How does a person look like? You're looking for signs of obesity, cachexia, abnormal fat distribution. Okay, all of this it's a pointer to all the several metabolic disorders that we have. Okay, the facial appearance is very important for patients with Down syndrome, for patients with multiple sclerosis, for patients with diabetes, for patients with all of those Cushing's triad. The way the patient look is going to be a pointer to the kind of disorder or the kind of treatment that you recommend for your patient. Okay. Furthermore, looking on the appearance, signs of dehydration of or edema, just to include for patients with diabetes, you're looking for any wound because patients with diabetic have problems with wound healing. So you're looking for any cuts or break in skin integrity under the skin. Like I said, check for delay wound healing. This may include diabetes, indicates diabetes. All right. So those are very, very, very important. The hairs and nails, you need to look at them just head to toe, cephalocaudal, like head to toe. You're looking for at the person from head to toe, complete physical assessment of the patient. Don't forget, first one is taken, second one, physical appearance, physical examination. So, like I said, the eyes, cataract, cataract, the neck, um, Check the thyroid gland for enlargement, nodules, or tenderness. The cardiovascular system, if the heart rate is high, tachycardia or bradycardia, if there's hypertension, all of this, they have their function. In tachycardia, it will tell you if probably hyperthyroidism, bradycardia probably hypothyroidism, hypertension probably having issues with catecholamines. Okay, monitor for signs of heart failure, and then you move ahead to the neurologic assessment. Okay, you see if the person is shaking or if there's any muscle weakness or sensory changes. All of these are very, very important. The third thing you need to do is lab test, diagnostic investigation. Diagnostic investigation. So these are just an array of tests that can be done, but you need to be specific um, when you are dealing with specific disorders. So blood glucose level. This is particularly done for patients with that complaints, patients with diabetes mellitus. So you can see the glucose level. You can order for the fasting glucose level, or we have the random as well, and we have the HbA1c. This one tells you the glucose level over about 3 months or 6 months, 3 to 6 months. So it will tell you if the blood glucose level has been stable or has been high over a period of time. We have the thyroid function test, which is particularly relevant for people that has symptoms of hyper or hypothyroidism. Electrolytes, EGR, very important for almost all of them. Basically, um, hormone levels, lipid levels, all of these are very important. Imaging studies, all of this too. Your CT scan, your ultrasound, your MRI, can use to assess the size, the structure, probably if you suspect tumor of the adrenal gland, of the adrenal cortex or medulla. All of this you can use your own MRI to see. We have the stimulation suppression test. We have the biopsy if you want to. Now, nursing consideration. We've talked about the patient education. From your history, you can determine what part of the lifestyle of the patient needs to be um, yeah, sorry, what part of the patient's history, you can determine what part of the patient lifestyle needs to be addressed. Are you eating too much? Are you stressed too much? Are you smoking? Are you working in a very dangerous environment? Do you live in a bad environment? Does your house have enough ventilation? So this is what you talk about under patient education, and it includes dietary modification. So you need to see if your salt levels are too high, if your sugar levels are too high. You need to abstain from sugary food due to your diabetes, etc. You need to monitor your patients, monitor their vital signs, their blood glucose level, and their hormone levels. They need support, psychological support as well. Just to note, endocrine system plays a vital role in maintaining homeostasis and regulating the metabolic process. So a thorough understanding is essential for assessing and managing clients. We must be skilled in conducting comprehensive assessment and interpreting diagnostic tests and providing patient-centered care to optimize outcomes. All right, now quickly we want to just scan through some common metabolic disorders. The first one here is diabetic mellitus, DM. Most of us know what diabetes is. That's when there's excess blood glucose in the blood, rather. And they are due to, it's classed into two. There are two main types. There are more than two, but for the purpose of this study, there are two main types. Type 1 diabetes mellitus. This just to make it easier to understand. Type 1 diabetes is when the pancreas cannot or is not producing insulin. So in type 1, the pancreas, there's no insulin production at all. Okay, and we call it insulin dependent diabetic mellitus. It is a type 1 DM and also called insulin dependent diabetic mellitus because there is no insulin production at all, either because the pancreas is not able to produce insulin or because of whatever reasons, there is no insulin at all. And under the type 2 diabetic mellitus, there is insulin available. There is production of insulin, okay? But the problem here is that those insulin are not being taken up by the cell. They are not sensitive. The cells are not sensitive. They cannot sense the insulin. They cannot take up the insulin. Okay, the insulin is there, but it's not functioning. All right, and this one is what we call as non-insulin diabetic mellitus. So, just as a summary, that's a major difference. And now, under the type 1 or insulin dependent, it happens when there's destruction of the pancreatic beta cells. Insulin is produced by the beta cell. Okay, when that beta cell is destroyed, either by autoimmune destruction or either by removal due to surgery, due to carcinoma, okay, and then there's no production at all. There's leading to absolute insulin deficiency. Okay, it can be caused by autoimmune destruction. It can be caused by viral infection. It can be caused by whatever reason it is. There is just no insulin being produced. And then again, type 2 diabetes mellitus, there is insulin, but there's insulin resistance in the tissue. All right. So the hyperglycemia results from impaired glucose uptake. So that is what causes type 2. And the complications are a lot. It affects all part of the body. It could cause you know diabetic ketoacidosis, mostly in type 1. It could cause hyposmolar glycemic state, mostly in type 2. We have diabetic retinopathy, okay? That is when the blood vessels in the eyes, diabetic affects the eyes, due to constriction of the blood vessels, of the ocular vessels. Diabetic nephropathy, that's when it affects the kidney. It has neuropathy. Neuropathy is when it's affecting the nervous system. The person cannot feel, does not have sensation because the nerves are dead. And that is why they are prone to injuries. Might hit his leg on something sharp, something dangerous, you cannot feel it, then there's wound. Okay? So it can cause cardiovascular diseases because all of the blood vessels are constricted, leads to stroke, etc. etc. It's a very, very, very dangerous disorder with lots of complication. So that's what the summary about diabetic diabetic mellitus. There's increased glucose in the body and it wreak havoc. Then another common one is thyroid disorder. It could be hypothyroidism, like I've said earlier on, and it could be hyperthyroidism. Okay, when it is hypothyroidism, that is when there's insufficient production of thyroid hormones. So the T4, T3, they are very low. And when they are low, what happens? The basal metabolic rate will be reduced. Okay, you are, yeah, it reduces the basal metabolic rate, and then symptoms like tired, you are always tired. Okay, you are gaining weight, you feel cold, your heart rate is low, your breathing is slow. Okay, you are just the person is just sluggish, everything is low. That's what happens in hypothyroidism. Whereas in hyperthyroidism is the opposite. Because there's excessive, you can see there is excessive production of thyroid hormones, okay, and then it leads to elevated BMR, causing weight loss because you are so active, you are you are hot, you are always hot, your heart rate is high, and then you begin to shake, causing tremor. It's worthy of note that in hypothyroidism, it's often caused by Hashimoto's disease. It's an autoimmune disorder. Okay, that's Hashimoto disease. Why hyperthyroidism is caused by Graves' disease. Okay, so that's very it's worthy of note. Just in case of the MCQ questions, there are quite a number of complication. But most importantly, for hypothyroidism, we have the myxedema coma. So either of them will lead you to coma. The hypothyroidism can lead to myxedema coma because the basal metabolic rate is so low and the body cannot keep up, the heart cannot keep up, it cannot keep up enough for survival. Then the person go into coma. That kind of coma is the myxedema coma. All right. And then in the hyper, because we are all active, your heart is racing, your body is hot, your brain is over functioning. You have what we call thyroid storm. All right. So that's presents with fever, tachycardia, and then all-time mental status. Okay. It's going to affect your mental ability. Adrenal disorders. These are the ones affecting the adrenal gland. Common one as well. Two listed here. We have the Cushing syndrome and the Addison's disease. Very opposite to each other. For Cushing syndrome, it is caused by the overproduction when there's too much of the cortisols. Okay. Uh, yeah, excessive cortisol levels. Sorry. All right. So, what could cause the cortisol level to be high, to be excessive? For instance, if there's a tumor, what the tumor does is that it increases this amount of cortisols being secreted. It increases the surface area of the organ because the tumor causes the organ to be quite bigger than normal. So it increases the surface area and then increases the amount of secretions, amount of hormones, amount of cortisol being produced. So tumors mostly can cause Cushing syndrome. All right. So what they do is when there's excess cortisol, it leads to more protein catabolism, fat distribution, causing obesity, I don't know, all of this, and glucose intolerance. So all of this happens because of when there's excess cortisol level in the body. And opposite, we have the primary adrenal insufficiency. That's the Addison disease. So this one happens because there's destruction. That cortex is destroyed, so it's not producing enough um, hormones needed. Okay, and this is because of infection or hemorrhage, or probably towards maybe trauma or surgery causes this to be insufficient. So we have results in deficiency of cortisol, aldosterone, and the adrenal androgens. Okay, and when they are low, it causes hypoglycemia, it causes fatigue, it causes poor stress response. Instead of flight and fright, you have a very poor stress response. Okay, you cannot respond properly to external stimuli. So, complication when there's Cushing syndrome, like I said, Cushing syndrome is when there's excessive cortisol level. So, you can have things like hypertension, you can have osteoporosis, you can have diabetes because there's too much metabolism going on, there's too much blood glucose available, and also infection. Whereas in Addison disease, it's gonna cause hypotension and shock, okay, because there's an adrenal crisis. Because everything is just low, then it leads to hypotension and shock. We have the parathyroid disorders. So what they do is like just like every other one, when you know the function of the organ, okay, of the gland, then you can tell what the disorder is gonna be. So we talked about parathyroid. We said it helps in prophosphate, phosphorus level. It regulates the calcium and phosphorus level. So when there's hyperthyroidism, that means there will be overproduction of the parathyroid hormone. It will be too much. There will be excessive amount of parathyroid hormone, and then this will now lead to increased bone resorption. Why does it lead to increased bone resorption? because bone is the primary place where phosphates and calcium are produced. Okay, so the bone will continue to wear out, it continue to produce more calcium and more phosphate, phosphorus from the bones, leading to the breakdown of the bones. The bones become brittle because there's so much work going on in the bones. All right, I hope that's clear. So excessive increased bone resorption will lead to hypercalcemia and hypophosphatemia. So when the calcium level is high, phosphate levels are low. Chronic hypercalcemia will cause kidney stones because of the excessive breakdown of calcium. It will form sediment, causing kidney stones. The bones will be porous. The bones will be broken down because too much is going on in the production of calcium, causing osteoporosis and some neuromuscular symptoms. Whereas opposite happens in hypoparathyroidism when there's a very low amount of parathyroid hormone produced, it will cause an hypocalcemia because not much is happening in the bone and hyperphosphatemia. Just to remind you, calcium and phosphate are inversely proportional, which means when there is low calcium levels, it will cause high phosphate levels. And when there are high calcium levels, it will cause low phosphate levels. So hypocalcemia will also lead to neuromuscular irritability, tetany, and seizures. Why? Because calcium is very important in action potential. It helps in the function of the nerves, of the muscle. It helps in muscle contraction. So when there's low calcium, it causes all of this irritability, tetany, and seizures. Complications: hyperparathyroidism, it leads to renal failure because of the kidney stones, because of the hypercalcemia, okay? And in hypoparathyroidism, it causes chronic hypocalcemia and cataract. We have the pituitary gland disorder. Uh, we talked about the production of growth hormone, which is done at the anterior pituitary. Okay, we have acromegaly and gigantism, either gigantism or gigantism, but the spelling is clear. Um, I think it's pretty straightforward. It is due to excess secretion of growth hormone. So too much growth hormone, and that is not regulated. That's when the negative mechanism is not functioning properly. When there's a fault with the mechanism, okay, then it causes excessive secretion of growth hormone, and then there's gigantism in children. That means they grow very tall. They grow really tall. A 5-year-old boy can look like a 10-year-old or 16-year-old boy because of the excessive growth hormone. That's in children. But in adults, it causes acromegaly, causing the enlargement of bones and soft tissues in the hands, feet, and face. So that's what happens. And then, okay, sorry. And then diabetic insipidus. We talked about the antidiuretic hormone. What happens is this antidiuretic hormone, just like the word says, diuresis means urinating. Okay, when you say diuresis, that means peeing, urinating. Antidiuretic means stopping urinating. Okay, so antidiuretic hormone is an hormone that stops you from urinating. That means it absorbs water. It absorbs the water into the body. It helps to absorb more water into the body to reduce your diuresis. So when this hormone that stops you from excessively peeing, excessively urinating is now deficient, it causes too much urination. excessive urination here or polyuria. Okay, so when there's polyuria, and because we are losing too much fluid, naturally the body compensates by making you thirsty. So you drink more. You lose more urine, you lose more water through urination, and then you drink more water because you are losing more water. That is because of the reduced antidiuretic hormone. That diabetic insipidus. So your ADH is low, causing you to lose more water by urination. Because you are losing more water by urination, the body compensates by making you thirsty, so you drink more. Okay. Now this can result in dehydration and hypernatremia. Because you are losing water, the amount of sodium in your body is so high, it becomes concentrated. All right, so causing hypernatremia. Hypernatremia is high blood sodium. So that's what happens in diabetic insipidus. That's the difference. Diabetic insipidus is different from diabetic mellitus. Please, we need to take note. So complications in acromegaly, it could be hypertension, diabetes, or cardiomyopathy. People with diabetic insipidus, very certain they'll be severely dehydrated, and also there will be electrolyte imbalance because they are losing too much fluid. The sodium levels in the body is getting high because they are becoming concentrated, so there's electrolyte imbalance. Metabolic syndrome is just a summary of everything we've talked about. Cluster of condition like obesity, insulin resistance, hypertension, and we talked about insulin resistance already. Okay, so um, the disorder of the pancreas helps to produce insulin. Okay, now when there's pancreatitis, when the pancreas is inflamed due to whatever reasons, it could be due to infection or due to auto digestion of pancreatic enzymes. Okay, it could cause by gallstones or alcohol abuse or even genetics or even infection. So what it does, it leads to tissue damage. Damage the pancreas itself becomes damaged because it's inflamed, necrosis, and systemic inflation. Complications for that is malabsorption. The pancreas produces digestive enzyme. Okay, so when the pancreas cannot do that, there is malabsorption. There is no proper absorption of nutrients in the body. It causes diabetics because the pancreas produces insulin. When insulin is not produced, it leads to diabetes and also can lead to pancreatic cancer as another complication. The gonads, right? For the gonads, we have PCOS, polycystic ovarian syndrome. You know, this is when there's hormonal imbalance, when there's all of the hormones are not in balance and it's affecting the ovaries. So it leads to irregular menstrual cycle. Hirsutism, that's when there's excessive hair growth and also can lead to infertility. We talk about hypogonadism, where the sex hormone levels are low, the testosterone in men, and in women, the estrogen. In men, when the testosterone is low, the male features of the body of the man is reduced. Okay, and then it also leads to reduced libido. It could cause infertility. Yeah, and then in women as well, when there's reduced estrogen in the female, it could cause infertility as well, and also affect libido, sexual drive. Complications are the same: infertility or cancer for polycystic ovarian syndrome, and in hypogonadism, it can cause cardiovascular disease and osteoporosis. So, just to note, the pathophysiology of metabolic and endocrine disorders involve complex interaction between the hormones, target issues, and the feedback mechanism. Like I said, we talk about the feedback mechanism. But when in all of this pathophysiology, something is evident, that means there's a malfunction in one of two. It's either the hormones are malfunctioning, they are becoming insensitive, okay, or resistant, or the target tissues are not responding to the hormones, all right, or the feedback mechanism are not working properly. So it's either one of these three that is causing it. Right, nursing process. So I've chosen just hyperthyroidism as a case study, a patient with hyperthyroidism. We're going to do a nursing process for this patient. Um, Nursing process involves assessment, um, nursing diagnosis, do some planning, um, intervention or nursing implementation, and then evaluation, evaluation, and then we call it a day. Um, like I said, this is it's a lot. It's a lot of conditions under the endocrine system, but we've just tried to do a summary, like a recap and overview of what we've learned already. If you have any questions, you are free to watch this video again, or just go to the app, look at the questions in the app. We've got lots of resources on the app to help you. This is just like a summary, a very quick recap. So I've done a nursing process for us for a patient with hyperthyroidism. So when we're asking an exam, a patient with a 50-year-old man or woman, whatever the case may be, has presented to you with history of hyperthyroidism. So do a nursing process for the patient. The first thing we do is assessment. And we've talked about assessment. The things we do under assessment is your history taking. You look at the symptom. What is this man or woman coming with? Okay. What is the past medical history? What are the medications? What are the lifestyle factors? Okay. And what are the physical? Then you go to physical examination. How does it look? Look at his body, and then let's carry on. So a thorough assessment is critical to identify the signs, symptoms, and complications of hyperthyroidism. The reason I put complication is because at the time when a patient presents to hospital, there may be complications already. Okay, sometimes patients come late to the hospital, and at that point there are already complications. Okay, so at that moment you are not only dealing with with the disorder, you should also deal with the complication. Right. So health history. In a patient with hyperthyroidism, these are the typical things that they present with. It may not be all of this that will be complained when you speak to the patient, but these are the typical symptoms of patients that suffer from hyperthyroidism. So there's weight loss despite increased appetite. The man will say, I eat well, I eat 4 or 5 times a day, I eat a lot of food, I do this, I eat a lot, but I am losing weight. Okay. Then I'm always heat, I'm always hot. Whenever I'm in the office, I feel hot. I want to take off my clothes, and then they sweat a lot. Some people sweat a lot. I sweat a lot. I have some colleagues that sweat a lot. So even though sweating alone is not a sign of hyperthyroidism, but it's a very um, common symptom that you need to have at the back of your mind. Okay, and the palpitations, tachycardia, chest pain, the nervous irritability, tremors, insomnia, can't sleep. All of these are symptoms of hyperthyroidism. Okay, and all of this you should be able to know why all of these are happening. You should know why there's weight loss despite increased appetite. You should know why there's heat intolerance. You should know why there's nervousness. You should know why there's fatigue or muscle weakness. You should know why there's menstrual irregularities or why there's decreased libido. You should be able to explain all of these symptoms as regards hyperthyroidism. Okay, when you know why the patient has all of this, then you can better care for the patient. You can suggest treatment remedies. You can now make a very meaningful nursing intervention. Okay. Now, past medical history. You want to know what is the past history of this patient. So is there a history of thyroid disorders or autoimmune disease or thyroid surgery? Maybe the thyroid is already taken off. You don't know. Or maybe there was a surgery on the thyroid. Maybe there was a past cancer, past tumor that was worked on the patient, and maybe the tumor is back. You know, you need to ask all of these questions. Then don't forget genetics, family history. Are there parents? Are there family brothers, sisters that have this condition? Okay. Medication. You need to know if there are any medication that the patient take that might cause or mimic these symptoms. Okay. Lifestyle factors, very, very important. Do not forget, it is part of history taking. Stress levels, smoking, drinking, dietary habits, workplace, very important. All right. When you finish with your history taking, then you go to physical examination. How does the patient look? You need to weigh the patient. You need to look for signs of weight loss. Okay. You need to look at the body of the patient. As you are talking to the patient, is he restless? Is he hyperactive? Okay, because sometimes the symptoms, the complaint of patients may not correspond to what is actually happening. A patient may come in and complain of probably reduced eyesight, reduced vision, but on your assessment, the vision will be okay. Patients may complain of weight loss, whereas could be optimal weight. Okay, parents could complain of one thing, but evidently could be something different. So, taking the patient history is not enough. You need to see for yourself. You need to take some physical examination. Look at the skin, moist. Does the skin feel hot? Is there any hyperpigmentation of the skin? There's any discoloring of the skin? Okay. Look at the eyes. All of these are complications of patients with hyperthyroidism. Protruding eyeballs, all of these are very important. We talked about Graves' disease. Okay, you need to have all of this. You need to know them. Look at the neck of the patient. Okay, so we're looking at the neck because the neck is relevant. That is where the thyroid gland is located. So if the patient if you are suspecting hyperthyroidism, you are not going to start looking at the leg of the patient or start looking at the hand of the patient. No, because it has no relevance to the disorder. But looking at the neck is relevant because that is the location. Okay, that's the location of the thyroid gland. So cardiovascular system is also very important. Why? Because the thyroid has a very huge impact on the cardiovascular system because it increases the heart rate due to increased basic basal metabolic rate. So all of this you need to know. Diagnostic tests, these are the ones specific for hyperthyroidism. You need to check the T1, I mean the thyroid function test, T3 and T4. Okay, look at the antibodies in Graves' disease. Imaging, you're gonna look at thyroid ultrasound. Okay, and then to see the size of the gland, and if possible, if needed, you can also go for MRI or CT scan. Right, nursing diagnosis. When somebody has hyperthyroidism, there are an array, a lot of nursing diagnoses that um, we can talk about. But at the moment, we're looking at just 5 years. Okay, and this is just five. If you want more, quite a lot available on the app. So please just subscribe so you can
How
have
do we
access.
get the sorry, how do we get the app, and what's the name of the app and all that, in case if those people that are watching are not on the
Yeah, the app is Cerebral RN app is the name of the app. If you go to your Google Play or Apple Store, just type Cerebral RN, CEREBRARN, and you search for it. It's there. You just download it, and then you have access to all of the information, all of the resources available at your fingertips. Yeah, I'll just talk about one of these quickly. Imbalanced nutrition less than body requirement. Why is it less than body requirement? Because There's increased baseline metabolic rate and there's weight loss. So if there's weight loss, that means there's not enough, nutrients for the body. It's less than the body required, less than the body requirement. There's also risk for decreased cardiac output. We have anxiety, disturbed body image due to people that have goiter or if the eyeball are swollen. Okay, then you have deficient knowledge regarding hyperthyroidism and its management. Your planning for this patient is based on your diagnosis. So you plan according to your diagnosis. So if the diagnosis is imbalanced nutrition, then you are planning towards getting the person to have adequate nutrition. Okay. If the patient is having anxiety, then your nursing plan, your planning will be towards the anxiety. Sorry, taking this. Okay. If it's deficient knowledge, your planning should be towards the patient having adequate knowledge about the hyperthyroidism and its management. So that's what you do on planning and your intervention. Okay. If the patient is having imbalanced nutrition, so what you do, your goal is to make sure the patient is achieving a normal and optimal weight. Okay. So you provide high calorie diet, high protein diet. You offer small frequent meal. Okay, you monitor the weight regularly and you collaborate with the dietitian. So all of this are what you do, to help the patient and your nursing goals and nursing intervention, really. And then you come back to evaluate. Nutrition, as a patient gained weight, is he maintaining the weight? Are the dietary needs met? We talk about anxiety. Is Mrs. Jones still anxious about the whole condition? Okay. We talk about knowledge deficit. Does the patient know? Does she understand? Does he or she understand the condition and the treatment plan now? Okay. So those are the things that you do as nurses. In your nursing process, assessment is very important. We've talked about the assessment, talk about what you do during assessment, which are very, very important, up to the evaluation of your patient. And now to conclude, this nursing process for managing a patient with hyperthyroidism involves a comprehensive approach to address a physical, emotional, and educational need. By implementing this intervention, nurses can help patients achieve optimal outcome and improve their quality of life. That will be all for tonight. Just a summary and a recap of what we've learned already on the cardiovascular, on the endocrine system. So we've done the anatomy, brief anatomy, and then just a summary of the disorders. If you have any question, please can you let me know?